I'm Irene de Boer. I'm from the Leiden University Medical Center, and I'm very happy to welcome you here today because we have a very interesting session that's focusing on recipients of IHS funding, and we have a lot of different programs that we're going to be honoring here today. So I'm very happy you're here to see this. And we're going to start right away because we have a lot to get through and we've got a lot to enjoy. And we start with Cédric Gollion, who will presenting his fellowship that he did in Copenhagen. And he is going to talk with us about participation in reform registration for migraine structural and functional magnetic resonance imaging before and after erenumab treatment.
So I'm going to start with the DTI analysis, which is structural MRI analysis, and if I have time at the end, with functional analysis. Here are my disclosures. So the background of the study was that it remained unclear whether there are differences in white matter integrity of the white matter tracts between migraine and controls and between migraine subtypes. Using DTI, some studies have shown differences and alteration of the white matter integrity in migraine, but some studies have not. These inconsistencies might be attributed to small sample size and heterogeneity within the migraine population and in the method used. So the objective of this study was to explore the microstructural integrity of the white matter of the migraine brain. REFORM study is a prospective cohort study of patients with migraine, analyzed at different time points. They were treated at the Danish Headache Center with erenumab, and assessments were done at baseline, 6 months after erenumab, and 6 months after stopping erenumab. Assessments included clinical assessment with interviews, PROs, MRI, provocation test, and biochemistry as well. So I'm focusing only on MRI at baseline. For those who are not familiar with DTI, DTI looks at water molecule diffusion. In the brain, water molecules diffuse along the white matter fibers, and making the water diffusion anisotropic. So we can calculate a fraction of anisotropy, we can calculate the diffusion along the white matter tract, which is the axial diffusivity, orthogonal to the fibers, which is the radial diffusivity, and also we can calculate the mean diffusivity. With that, DTI can calculate and build a skeleton of white matter fibers in the brain, and also analyze the integrity of these white matter fibers. Roughly speaking, we have these 4 variables. When you have axonal loss, we observe decrease in fractional anisotropy, decrease in axial diffusivity, and increase in mean diffusivity. And when there is demyelination, we observe increase in mean and radial diffusivity. Here are the results. So you can see that almost 300 patients with migraine were included. They were compared to 160 controls. Healthy controls. You can see that almost 1/3 of these patients with migraine had also migraine with aura, and almost 2/3 of this patient had chronic migraine. They were mostly women, age 41 years old, with MMD of 13 migraine days per month. I would like to draw your attention to the fact that almost around a quarter of patients were scanned during the ictal phase of migraine. Okay. Here are the results. They're very simple. There are no difference between migraine and controls and between all migraine subgroups. Here you can see almost 300 patients with migraine, 160 controls, analyze and compare for these 4 variables of DTI. We found no significant difference. We also compare migraine with aura, migraine without aura, and healthy controls. We adjusted for age, sex, and chronic migraine. Again, no significant difference. We compared also chronic migraine to episodic migraine and healthy controls, adjusted for aura, age, sex. Again, no difference. We also analyzed migraine patients scanned during the ictal phase of migraine. We compare them to the healthy controls, but also compare them to migraine patients scanned without any pain, totally interictal. No difference. We had 46 patients. We had unilateral pain during the migraine attack, so we decided to compare the painful side to the pain-free side, and again, no difference. We also made correlation with clinical variables, including mean migraine days, mean headache days, also numerical rating scale, and we found no correlation between DTI values and these clinical variables. I won't go through all the lines and columns of this table. This is the presentation of all these results. The lowest p-value observed is presented in this table, and again, no significant difference. So what do we learn from this study? That's a good news for our patients. There is no argument for microstructural abnormalities in migraine. The white fibers are preserved. We can also, the fact that DTI variables were not correlated to clinical variables suggest that there is no cumulative damage due to migraine. And we can also say for sure that DTI is not a viable biomarker for migraine. Of course, the study is not without limitation. All phases of migraine were not accounted. I mean, we did not analyze people, migraine patient during the prodromal phase, postdromal phase, in a longitudinal way. So clearly, this study does not exclude transient and reversible changes in DTI in some specific tracks during the migraine cycle. There is no longitudinal analysis, so we cannot absolutely be sure that there is no cumulative damage over time, but the fact that there is no correlation with clinical data does not suggest this hypothesis. In conclusion, cerebral white matter is intact in people with migraine, suggesting that structural alterations in white matter do not play a central role in migraine pathophysiology. I see that I have a few minutes left, so this is the publication in Cephalalgia. Just to remind that when you publish in Cephalalgia, you're invited to create a graphical abstract, and we're always enjoying nice graphical abstract. The second part of the work accomplished at the Danish Headache Center was also functional MRI in patients scanned during the ictal phase during the aura phase. It is quite rare to have patients scanned during the aura because of its unpredictable and short-lasting nature. But when you scan 100 patients with migraine with aura, fortunately, sometimes some patients have an aura during the MRI. And we had a total of 6 patients scanned during the aura phase, 3 with only visual aura and 3 with somatosensory aura. When patient reported an aura, we started functional MRI with brain activation. That was a visual activation with a flickering checkerboard. And I would like just to show 2 patients. The first presented with a visual aura. We started the functional MRI. We can observe a mix of blue and red, meaning that mix of hyperactivity and decreased activity of the brain within the occipital cortex. A few minutes later, the patient reported somatosensory aura. His symptoms were bilateral. It was tinglings in both ends and forearms. And what we can see is that there is a hyperactivity in the somatosensory cortex a few minutes later after he reported these symptoms. But we cannot find and observe a front of hyperactivity from the occipital cortex to the somatosensory cortex. This is something new appearing in the somatosensory cortex. The second patient had a somatosensory aura first. The sensory aura was purely right-sided. He felt paresthesia spreading from the face to the arm to the leg. And a few minutes later, 30 minutes later. Actually, he had a visual aura which was bilateral with blurring and darkening in the periphery of the visual field. And what we can see is that in the beginning, when he has his sensory aura, there is somatosensory cortex hyperactivity, and this hyperactivity gradually spread backward to the occipital cortex. You can see clearly on the posterior view, in the beginning there is nothing in the occipital cortex, but a few minutes later on the fourth slide, you can see in the fourth slot there is clear activation of the visual cortex when the patient reported a visual aura. So what do we learn from this observation? Is that we can observe bilateral alteration of brain activity in patients with unilateral symptoms. Why? Maybe because of remote alteration of cerebral activity during the course of a cortical spreading depression, or maybe because of multiple simultaneously occurring cortical spreading depression. Second, we observe the absence of progressive hyperactivity from the occipital cortex to the somatosensory cortex in one patient. That might suggest the possibility of multiple independent CSD. And three, we also observe something unusual, gradual antero-posterior spread of hyperactivity, which contrasts with the traditional propagation patterns described in the classical view of aura, migraine aura. So our finding might suggest the potential of multiple simultaneous cortical spreading depression with variable trajectories as the migraine aura progresses. This observation highlights the dynamic and multi-phased nature of migraine aura. Thank you again. Thank you for your attention.
Thank you so much. We have time for one quick question. I already saw a hand raised, so.
Congratulations, Cédric, on this award and this wonderful study. I was just wondering, a very quick question. In the other atypical features with regards to your patients, there's also the fact that the majority of them had bilateral symptoms, both visual and sensory, right? How would you comment on that? Because I guess we're canonically used to seeing unilateral clinical symptoms of aura. What do you think that's due to?
But maybe because of multiple cortical spreading depression, you see. So a quarter of patients report simultaneous visual and sensory aura. It's not always sensory and then visual and then phasic and so on. So there is multiple scenarios. 25% of patients have simultaneously different aura symptoms. So it could be visual and sensory. It could be sensory on both sides, maybe because of multiple CSD. That's an hypothesis.
Yeah, I agree with that. And do you think that maybe then your sample influenced this, this final conclusion then? Because maybe you had a sample where the symptoms are multi-spread in different areas of the brain. I wonder if that is representative of the typical aura patient.
Yes. I think they are representative because it's not unusual aura like motor aura, brainstem aura, things that are debated. They had classical aura. Thank you.
Okay, thank you so much. Something to discuss more in the break, I would say. Thank you so much for your presentation. We'll have to move on to the next one. And it's my special pleasure to announce the next speaker, as I'm the chair of the Junior Forum, and this is one of the recipients of the Junior Research Grant. Wei Dai is going to talk with us today about graph theory-based transformer architecture for migraine biomarker detection and multi-center functional MRI datasets. I can't even pronounce it, so I'm very interested to hear what you have to say about it.
Okay, thank you, Dr. Boer, and good afternoon, everyone. I am Wei Dai from Chinese PLA General Hospital, and I am the recipient of the Junior Research Grant 2023. And I would like to express my gratitude to the IHS for their support, for their putting their faith in me. And it is my pleasure to present the results of study entitled Migraine Classification with Functional Interaction Learning from Functional MRI Volumes. So I have nothing to disclose. And here we can see the routine MRI images. As for tumors or severe ischemia, even someone who has never been trained can easily identify the lesions on the structural MRI. But when it comes to headache, the images we see are usually as normal as healthy populations. So usually, we use the routine MRI only to exclude secondary causes of headache. And the diagnosis of migraine, cluster headache, or others, primary headaches, are entirely based on clinical criteria, which cannot fully capture their heterogeneity or the underlying pathophysiology. And here is the structural MRI image and the functional MRI image of the same person. And on the left, we can see, well, the SMRI provide the three-dimensional images of brain anatomy. The fMRI provides four-dimensional data that include a series of three-dimensional brain volume images acquired along the temporal dimensions. And they can show the changes in blood oxygenation levels associated with brain activity. And these fMRI images can provide us much information for brain functional changes and for brain functional disorders like migraine. So when it comes to the analysis of MRI and the MRI-based classification model, the most classic model is functional connectivity-based approach. And the functional connectivity between two manually predefined brain regions is calculated by the correlation coefficients between the time series of the two regions. And they can form into the FC matrix and work as input for the classifier. And the sum of the regional FC strength can be ranked and turned into the FC-based biomarker brain map. And now, in our study, we propose a deep model, and we name it as BrainFormer. Our model then computes directly on single volume fMRI data for migraine classification. And it can enlarge the sample sizes for training, and the point of peak response can be directly localized on the fMRI volumes. So next, I will briefly introduce the basic structure of our model, how it works, how do we evaluate its performance, and what we can get from this model. So this is the basic structure of our model. It consists of three branches. And firstly, we have a data normalization layer. It can unify the data from multi-site and unify their distribution. And secondly, we have a convolution stem, and it's for feature extraction from the fMRI volumes. And then we have a parallel structure, and it consists of three branches. The first line is the three-dimensional convolution branch. And I can capture the detailed information with a voxel-wise receptive field. And it computes on its original resolution. And the second line is the window partition attention block. So this block is for computing the global correlations. And on a window partitioned volume, it computes on the half of its resolution. And the third line, we call it global self-attention block. It's also for global correlations, but it computes on a quarter of its resolution. So it's very computational efficient, and it just saves the workload, and the workload is only a quarter to the power of 3 of its original resolution. And then we design and implement a mutual interaction, and they can first combine all the information from the 3 blocks and then distribute them to the others. So it can allow the mutual guidance between these blocks. And here are the detailed structures for the MSA block, and for the WPA block, and also for the GSA block. And now we have our data. And firstly, we randomly split the data into 80% for training and 20% for testing. We shuffle these data and put them into our model. And then after the parallel branch, the data will vent will go into a classifier called a fusion block, and it will just output the classification results. And firstly, we test our model on our own dataset. We call it ECHO, and it contains 107 migraine participants, 38 MOH, and that is medication overuse headache participants, and 52 healthy controls. And we can see that the accuracy results for migraine and MOH are around 85%. But for healthy controls, they nearly 100%. And the F1 score, which is for balanced precision and recall, for migraine is 80%. But for medication overuse headache is only 66. And we assume it may due to the limited sample size. And then it naturally leads to a broader question. And what about our model's performance on other brain diseases and categories? So we move on to test our model in public data sets, including 8 diseases, including major depressive disorder, Alzheimer's, mild cognitive impairment, autism spectrum disorder, and Asperger's, and also attention deficit hyperactivity disorder. We would like to test how our model performance on these data sets. So when doing the performance, we also compare our model with other representative models that have been published, and including the GCN-based model, CNN-based model, and also transformer-based model. And here are the averaged accuracy results. And we can see from the red color at the best performance and the green color at the second best performance. And here are the figures of the results of the table we just see. And then we wanted to understand that how about functional connectivity? We want to understand that the specific value of FC. So we take the functional connective feature as input and compared the results with our brainformer model. Interestingly, the FC features provided a consistent baseline, delivering comparable results and often slightly higher accuracy in every single one of our 6 data sets. And last, we implement a gradient-based localization method, and it can directly locate the point of peak response on fMRI volumes. One of our key strengths of our model is to precisely locate the peak response directly on volumes and output a probability distribution. And from this picture, we can see that some of the peak response point falls onto the white matter and even for ventricles. So next, we apply a brain mask for this. We apply brain mask and cerebral spinal fluid mask, white matter mask, as well as green matter mask on our model. And we can see that the CSF mask and white matter mask significantly reduce the performance and reduce the classification accuracy. And however, using the brain mask or the green matter mask provide similar results to using no mask at all. Here are the conclusions. In this test, we propose brainformer multi-resolution parallel architecture working on a single fMRI volume for migraine. And experiment results on 8 diseases and 6 data sets have demonstrated the fine generalizability for multiple disease classification and a good transferability for multi-site data. And our model can directly locate possible disease-related activation map on fMRI images and motivating future studies. I would like to briefly introduce our hospital and our department. And we are the neurology department of Chinese PRA General Hospital, and we have an international headache center. And the department is led by Professor Shengyuan Yu and Professor Zhao Dong. They're also here today. And we have 8,000 to 10,000 outpatients per year. And we have a headache ward for cluster headache, chronic migraine, and etc. And we also have many therapy approaches like TMS, DBS, and we have examination approach, including high-density EEG, multimodal MRI, and we held Headache Academy and educational program, and also the National Headache Congress every year. This is the photo of our team. And last, I would like to express my profound gratitude to the International Headache Society and to the president, the board, the members, and also Secretary Carol. And at the time I received this support, I just complete my doctorate and start my postdoc career. These two grants, the Junior Research Grant and the Secondary Headache Grant, are the two first grants I've ever received. And these grants not only enabled my initial work, but also allowed me to secure further funding in the following years. And this is the study we have completed, and it has been published in Annals of Neurology with the support of this fund. And so thank you for believing in me and when it mattered most. And that's all for my presentation. Thank you for listening.
Thank you so much. It's great to know that the money was well spent, and also that you were able to get additional funding using the work that you did. It's really great it was so successful. Then I would ask our next speaker to come to the floor. We are going to learn from someone who received the seeding fund for the Child and Adolescent program. And this is Dr. Massimiliano Valeriani, and he will talk with us. Sorry for butchering your name.
It's a challenge.
It's such a beautiful name, so please explain it yourself. And he's going to talk with us about early alterations of cortical thickness and gyrification and cortical connectivity in migraine without aura, a prospective MRI study in pediatric patients.
So since the surname was not enough difficult, I added something in the title. Okay, these are my disclosure. Thank you for the introduction. So I saw that in this session there were practically all studies about the use of magnetic resonance imaging to study the pathophysiology of migraine, provide biomarkers. So all of you thus are quite aware about the potential of this technique, of the updated methodologies of MRI in increasing our knowledge about migraine pathophysiology. Here there is a very recent review paper with several outstanding authors which showed the principal results obtained with structural MRI in migraine. You see that modification of the cortical thickness have been demonstrated in several brain areas in both the interictal and ictal phase of migraine and even during the aura. Interestingly, some of this modification can be reversed, being probably directly linked to the neuroplasticity capabilities of our brain. So the problem is that, as the authors underscore, that there is a great inconsistencies among the different studies, suggesting that the most standardized methodology should be used to really increase our knowledge and mostly provide a reliable biomarker. This is an earlier review about functional magnetic resonance. fMRI has provided information about the connectivity of the different brain areas, and you see in this systematic review the connectivity was found increased or decreased in patients with migraine in several brain areas, including insula, which is a well-known hub for pain processing, and in brainstem hypothalamus, whose importance in migraine pathophysiology is well known. But what about the children? There are really few studies with neuroimaging, with the structure or functional neuroimaging in children with migraine. This is a pity, because in children, possible abnormalities of cortical thickness or connectivity are likely to be more closely linked to the pathophysiology of the disease, since the influence of comorbidities of the environment, but I would also say of drugs, is surely lower than in adult patients. Of course, the neuroimaging study raises some challenges in children, because we need a certain cooperation, collaboration from the patient, and you know that especially under 7 years, we need general anesthesia to perform an MRI, and this of course can bias the results of the examination. And moreover, there is I would say chronic difficulty in getting control data, normative data, and this is something which is shared also by other techniques of investigation, for instance, neurophysiological investigation too. So this is a study we published a few years ago using structural MRI, and if we focus in this study on cortical thickness and gyrification index, we compared 72 patients with migraine without odor with 282 control subjects, 18 years of age. Here there are our main results. As for the local gyrification index, we found in patients a reduction as compared to control in the left superior parietal lobule, and among patients, in female, there was a reduced gyrification index in the right temporal gyri and in the right posttemporal gyrus. Interestingly, we possibly related this difference concerning the primary auditory cortex between female and male patients to the lower incidence of phonophobia in female than in males, which we found in our patient, but it is a finding shown also in other study. As for cortical thickness, we found a reduction of cortical thickness in the older than in younger patients. We are speaking of 18 years patients. In the left primary somatomotor area and in the temporal lobe and in the paracentral lobule. This is interesting because the fact that the cortical thickness is reduced in older adolescents as compared to younger children possibly means that this parameter is strictly linked to migraine pathophysiological mechanisms. And moreover, in patients with showing nausea or vomiting, we found an increased cortical thickness in the opercular region as compared to those without these symptoms. This is the study we performed also thanks the founding of IHS. This is based on a new technique of analysis, the morphometric similarity mapping. Till 1 month ago, I would have said that this technique has never been used in patients with migraine, but in August there was the publication in Cephalalgia of a paper of Massoud Shina group investigating older patients with migraine and post-traumatic headache, but it has never used in children with migraine. And this technique is based on the assumption that if two brain areas are similar from a morphometrical point of view, they are likely to be also axonally connected. These are our aims. We would have liked to find the difference in MSNs between patients with migraine without aura and controls, and to link some findings of MNS with the characteristic of migraine. Here are our methods. We studied 98 patients with migraine without odor against 81 control subjects. And here are our results. When we compare patients versus control, we found an increased morphometric similarity networks in the left middle inferior temporal gyri and in the left superior temporal sulcus, and in the singular gyrus, the posterior part of the left singular gyrus. When we compare the male patients with the male controls, we found increased morphometric similarity networks in the left superior temporal sulcus and in the anterior part of the left singular gyrus and the left cuneus. Again, among patients, male as compared to females had increased morphometric similarity in the left superior temporal sulcus and in the left anterior singular gyrus, and males with more than 5 migraine days per month showed a reduced morphometric similarity in both temporal lobes. So, to discuss our results, when we compared the patients with control, we found that the abnormal morphometric similarity network data concern especially regions such as the temporal regions and the cingulate cortex, which are part of the so-called pain matrix. Interestingly, while male patients showed abnormal morphometric similarity networks abnormalities in a region such as the temporal region and the right precuneus, which are linked to pain processing. In females, the involvement of the frontal lobe and the right precuneus suggests an abnormal conscious information processing. So to conclude, we think that the updated techniques of MRI can provide important pathophysiological information even in children and adolescents. And actually, it's possible that in this particular population, we can have some information which is more closely linked to pathophysiology of the disease, since the other influence, environment, drug, comorbidities are lower than in adulthood. The difference we found in both studies, the one focusing on cortical thickness and this one with morphometric similarity mapping between male and female, can represent the rationale explaining the well-known gender differences in phenotypical characteristics and in epidemiology. So, of course, we must be cautious in interpreting our findings because they must be replicated, and for this reason it is important that there should be a standardization of the methods, and IHS can promote this standardization to really have solid and reliable results with these techniques. Finally, I have to thank several people of our headache center, of our neuroradiology unit, and our physicist. And mostly I have to thank IHS Child and Adolescent Committee to have founded the study. Thank you very much.
I just had a question about the difference in the MSNs between the males and the females, which was really fascinating. And it seems like they're quite different in terms of the areas that have increased MSN. On a everyday sort of patient interaction level, how do you think that manifests in terms of the pain symptoms male patients experience compared to female patients?
So I'm not sure I have understood well. You ask how does this difference can be translated in symptoms?
Correct. Yeah.
Yes. So the interpretation we try to provide is that you saw in my slide. So while in males there is a great involvement of region directly related to pain, in females there is the involvement of we can say more cognitive region. So as if the more emotional brain areas were involved in females than in males. While in males, there should be an involvement of region more related to perception, to sensory discrimination of pain. But of course, this is just a speculation. What is interesting is to note that there is some difference, and this substantiate in some way the difference we can observe in clinical on the clinical ground.
Thank you.
Thank you. Can I ask a follow-up question very quickly about something else? I'm
Yes,
just wondering.
Yes, with pleasure.
You dichotomized your data based on 5 monthly migraine days, I believe?
Yes, we divided, so we try to separate patient with less than 5 migraine days per month from those with more than 5 migraine days per month. Of course, the ideal situation would have been to divide, to have a division between episodic and chronic migraine, but unfortunately in our sample we had just few patients with chronic migraine. That is why we couldn't compare those with chronic with those with episodic. But so there are several elements in the literature suggesting that in episodic migraine there could be made a differentiation between those with a low frequency episodic migraine, less than 5 migraine attacks per month, from those with a high frequency episodic migraine, more than 5 migraine attacks per month.
So fortunate for the children that they didn't have the chronic migraine.
But but unfortunately,
also be something to think about using it as a continuous measure instead of dichotomizing. But maybe we can talk about it more later because the screen is angry at us and it's red. So I will catch up with you later. Thank you so much.
Thank you for the question.
So with that, I would like to ask our final speaker to come to the floor. We have the pleasure to listen to the recipient of the Headache Science Award for Mid-Career Researchers. And I'm very happy to introduce to you Francesca Puledda, who will talk with us today.
Thank you so much, Irene, for this introduction. And I'd really like to start by thanking the IHS for this incredible award that they have given me. I'm really incredibly proud to be representing the IHS because, as you know very well, I truly believe that societies like the IHS that promote young and early career, in my case more mid-career scientists, really help shape headache science for the future because it allows us to choose headache as a career in our life. So thank you very much. These are my disclosures. And it's really a great pleasure to talk to you about some of my research highlights from the past few years. I've been actually interested in headache and related disorders for some time now. And when I first joined the King's College London headache group, I very quickly became quite fascinated with this novel condition that had only been characterized a couple of years before, called visual snow, that I think many of you now know, but at the time we knew very little of this condition. We knew that it was a continuous visual phenomenon characterized by this static in front of a person's vision that was associated with migraine, but that was also quite different from migraine. And so I had the luck of being able to engage in a PhD studying this condition. And I collected some clinical data from over 1,500 patients with the syndrome and the phenomenon from all over the world. And this gave me the opportunity to really deeply phenotype these patients and kind of confirm the classification of the visual snow syndrome that is characterized by also these associated intrusive bothersome visual symptoms, such as, for example, after images, flashes and toptic phenomena, and increased sensitivity to light, which is also quite fascinating because it's a common feature with migraine as well. And in this context, I also used a statistical method called the latent class analysis because I was very interested in understanding if there were possible endophenotypes. So if we could classify patients with visual snow based on their symptoms to look at possible groups and maybe different approaches in management. But I think it was quite interesting. We were quite surprised to find that actually visual snow is not characterized by endophenotypes, by clinical subtypes, and it actually exists on a clinical spectrum, much like many other neuropsychiatric conditions that we know. So on one end of the spectrum, we have people who are barely see some form of static, are not necessarily affected by it at all, maybe even consider it as normal. They've had it for their entire lifetime. I've been approached by numerous friends and colleagues and other fellow neurologists that have asked me, why are we studying this? Doesn't everybody see a little bit of static? And the answer is obviously no, but it tells us that it is not necessarily a disorder in this case. But of course, on the other end of the spectrum are the people who we have to worry about, the actual patients. They have a very high symptom load. They have a lot of the associated symptoms, maybe all of them, the ones that I just mentioned before. And they're also highly comorbid with migraine, aura, tinnitus, but also difficult to treat psychiatric conditions like anxiety and depression. And in fact, these patients are very difficult to treat. And we understood this pretty early on when we started noticing that the majority of the classic migraine medications are not helpful for these patients, not just the acute treatment, which is understandable since they don't have pain, but also the classic preventives. And more recently, we've learned from Christoph Schanken's study that even the novel CGRP antibodies and treatments do not affect these patients. And so in this particular study, we did a questionnaire-based study on 400 patients with visual snow, asking them to tell us if there were any medications that they had tried in the past of many broad different categories. We were very open to any possibility to treat them, to tell us if they had had any changes in their symptoms with these drugs. And unfortunately, you can see that the majority of classes have absolutely no effect on visual snow symptoms, with possibly the exception of certain anti-epileptics and also of benzodiazepines, as I highlighted there. But this is not necessarily important for management because we wouldn't treat a patient with a chronic condition with something like a benzodiazepine for tolerability issues, but it does tell us a little bit about the possible pathophysiology, and particularly of hypothesized hyperexcitability in the cortex in these patients. And in fact, understanding a little bit about the in-depth pathophysiology of visual snow has been one of my main research interests in the past few years. And during my PhD, I embarked in the first MRI study in this patient population. Only one neuroimaging study had been done prior to this, and it was a PET study conducted at UCSF that showed us that there were areas in the associative visual cortex, specifically the lingual gyrus, that were hyperactive, hypermetabolic in these patients. So we conducted this multimodal MRI study. We looked at structure and function of the brain, and we found that there were changes in the structure, for example, with increased gray matter volume in the primary and associative visual cortex, area V1, area V5, but that actually extended beyond the visual system as well, and even included areas like the cerebellum and the attentional networks. And this was actually confirmed with functional studies, such as this one, that use ASL, arteriospin labeling, that indirectly measures neuronal activation. And you can see that there's a widespread network of altered function in patients with visual snow that, again, involves areas of the attentional and salience networks. And we also confirmed changes in metabolism in these patients with spectroscopy. In particular, we found altered anaerobic metabolism in the lingual gyrus. And with canonical functional bold MRI, we again found changes in the activation in regions of the salience network, and specifically the anterior insula, which is a very relevant area, not only because it's also found to be present in fMRI studies that show alterations in migraine and aura, but because it's part of the salience network, the network that allows us to select between stimuli that are relevant and those that are not. And in fact, I've also been very interested in understanding a little bit about the comorbidity, the complex association between visual snow and migraine, but also and especially with aura. And this, I think, is incredibly fascinating because, as you can see from this very nice design that my colleague Dr. Viana made, the typical symptoms of aura that we can see on top can sometimes present actually with the typical symptoms of visual snow and vice versa. And I won't go much into this because if you're interested in the topic, do join us tomorrow because we will be having a very heated debate with the forefathers of visual snow, Professor Peter Goadsby and Christoph Schanken, discussing these aspects in room 1A. And just quickly, in fact, to study these aspects a little further, more recently in a study that we published in Annals of Neurology, we use a particular neuroimaging technique called REACT that enable us to inform on previous functional connectivity data from our patients with different metabolites of interest. And again, here we were quite holistic. We looked at different metabolites from PET and existing PET and SPET maps from the literature. And so we looked at dopamine, glutamate, GABA, serotonin, really a broad spectrum, and even different receptors of serotonin, 5-HT2A and 2B. And we found some really interesting changes, specifically pertaining to the serotoninergic and glutamatergic networks that were common to visual snow and migraine with aura in particular. And the interesting thing is that some of the areas that were involved were particularly related to the associative visual cortex as well. And as you can see there, one of these areas was V3, V3A. And perhaps many of you remember that this area from the seminal studies of Hachicchiani that showed us the cortical spreading depression with bold fMRI and aura, this is the area where actually aura begins. So this is really highlights the interesting connection between these two conditions, that it's not just clinical. And in fact, we're looking at these aspects of cortical excitability and connectivity in more detail recently with some neurophysiology studies. Non-invasive neurophysiology is a really powerful tool. And in particular, we are looking at using a technique called TMS-EEG that allows us to really look at neural networks, at cortical and also subcortical function, and directly look at thalamocortical circuits and certain neurotransmitters like glutamate and GABA. And I won't go into the details in the study and the results that we're finding, but Viviana is actually presenting this data, some really interesting data that we're finding in patients with visual snow. So if you are interested, do talk to her. She is presenting her poster tomorrow. It's poster 410. And again, if you are generally interested in the topic of visual snow, do keep watching this space because we've just received some further funding from the UK Research Institute to investigate this condition. And we're particularly interested in doing some advanced neuroimaging that will enable us to look at spectroscopy, for example, at 7 Tesla. But we're also going to characterize these patients from a neurobehavioral perspective because ultimately we're looking at a condition where there's an alteration in the processing of sensory information. So this, for example, is a very neat and simple to do model that looks at something called motion-induced blindness. So if you're a healthy person, you have a normal sensory cortices, you look at the central dot, the moving green dot, and while you're looking at that, the static yellow dots in the periphery disappear because your brain considers them as irrelevant, as non-salient. And we believe that actually people with visual snow do not have this mechanism healthily implemented. We're also looking at aspects, for example, of augmented reality as a possible treatment or biomarker of visual snow. So here I conclude my presentation, and thank you so much for your attention.
Well, thank you so much. Unfortunately, we don't have time for questions, but Francesca will be here for the rest of the conference, so please ask them to her. Thank you all for coming. And also, I think we are very appreciative of the IHS who made all these excellent projects possible. So thank you so much.